well-known hepatobiliary surgeon in Sri Lanka. He's a liver surgeon as well as a pancreatic surgeon. He's a senior lecturer in Faculty of Medicine, Colombo. Actually, he's a very good person to discuss these topics because he has a lot of research activities, a lot of studies on this topic, and as well as he's a well-known surgeon on this topic. Therefore, I think you can get a lot of knowledge by listening to him, and he can share his experience with you, and it will improve your clinical knowledge on this subject. Dr. Duminda Subasinghe.
Good evening, and thank you very much, Dixon, for your kind words of introduction. It's after a long time we are seeing. He's one of my long-term friends, especially when I worked as a registrar during my peripheral appointment at Kurunegala. Nice to see you, and thank you very much for your kind words. And also, I congratulate on you this activity, which is I feel is very useful, and you are doing this for the 8th time. With that, would like to come to our topic proper, obstructive jaundice, which is actually a very important clinical topic. I know it's short term, our goal is final MBBS exam. This is why we are discussing this long case. But beyond that, also it's a very important clinical topic. Whatever the setting you work, especially in the adults, you need, because that is very important in terms of patient care. So I would like to keep this lecture very informal. If you want to ask questions, you need to clarify very facts, you can do at any moment. I will finish this my talk by 45 minutes, and let's keep 15 minutes for the discussion as well. So if you look at during next 45 minutes, this is my agenda actually. These are your learning objectives to understand and explain the anatomical and pathophysiological basis of obstructive jaundice, and how to get we need to be competent in how to get a proper, very concise history and examination in a patient with obstructive jaundice. Because primary aim of this lecture and the primary aim of you all is to become a good first contact care doctor who can get a decent history examination of a patient with obstructive jaundice, because you all are going to see this patient first. Then, in that process, to interpret the key laboratory findings, how to plan imaging investigations in terms of arriving in a diagnosis, as well as to make curative or palliative plans for these kind of patients, and briefly outline the principles of management of common benign and malignant conditions, which are the causative factors of this presentation. So in a nutshell, this is our aim. Now, in your long case, in the wards, in the exam, you will find a patient. So we need to, first straight away, we need to confirm that your patient is having obstructive jaundice. So these are the cardinal features. So deep icterus, everybody knows what is icterus. This yellow is discoloration of sclera, very briefly. And then certain patients, they will get pruritus due to the deposition of bile salts in the skin, which is an irritant, but not all the patients. And the dark urine, again, it results in always in all patients. This is a more reliable and sensitive clinical symptom, objectively sign by looking at the urine to confirm your obstructive jaundice. We commonly say your tea color urine, the Coca-Cola color urine, so various things, dark color urine. Another feature is pale stones. Now, if you put all these things together, that will define your obstructive jaundice. So, exam is a very time-limited, time-tested thing. You will get 15 minutes, 10 minutes for history taking, 5 minutes for examination. So, you need to be very organized to catch up these things at very early stages. The next question, when you get that information, again, just briefly to summarize, every complaint there should be a duration. Now, if you have obstructive jaundice, so we need to define is 4 months, 3 weeks, like that. So we'll go ahead our slides and we'll discuss these things in more detail. Then the next question is, we need to find out in any clinical setup why it happens, due to what. So that's what is the cause, and where's the obstruction. So to find out these things before coming into this, so we need to know the anatomy of our biliary system. Now, if you look at the diagram on your right hand side on the screen, you know the anatomy of the extrahepatic biliary tree. You have gallbladder, you have a cystic duct, common hepatic ducts, which will go in the subsequent slide. So we need to find out where is the obstruction and due to what, whether it's benign or malignant. If so, what is the etiology? Again, this is a very theoretical slide because obstruction could be due to something within the lumen, which we call intraluminal, and it could be within the wall of the bile duct, which is intramural. It could be something pushing the bile duct from the outside, which is called extramural. So, depending on that, theoretically, these are the possibilities. Common etiologies, intraluminal, your gallstones. Other things, strictures, could be malignant, could be benign, especially the benign strictures in the setting of chronic pancreatitis, because the last part of the bile duct goes through the pancreatic head. So when there's fibrosis going in the pancreatic head area, it can result in a benign stricture in the bottom end of the bile duct, the most distal end of the bile duct, which can cause obstructive jaundice. Then other extraluminal, again, it could be like, although it's extraluminal, it could be something infiltrating into the bile duct externally, like in pancreatic head, periampullary tumors, then the lymphadenopathy in the porta hepatis area. And these are the common etiologies we need to arrive at a diagnosis at the end of our exercise. Now, common causes of obstruction, again, if I classify everything if I simplify everything into a diagram, so biliary calculi is one of the common. The thing is malignancy. Malignancy could be proximal malignancy, biliary malignancy was a distal malignancy. Proximal malignancy, proximal means towards the liver. We know cholangiocarcinoma, which can happen in anywhere in the bile duct, even within the liver, which is called intrahepatic cholangiocarcinoma. But to cause the jaundice, there should be some blockage of the biliary duct system. So, intrahepatic cholangiocarcinoma, again, which can happen in the Hilar region, which we call Hilar cholangiocarcinoma. At the bifurcation of the bile duct, it's here actually, this area. Then, again, your gallbladder tumors, if it extend along the cystic duct, if it can involve in the callous triangle and if in the bile duct, again, it's a cause of malignant cause of bile duct obstruction. If you go to the bottom end, again, as I said, periampullary tumors, ampullary tumors are the common reasons. So these are one set of disease groups. Then the benign biliary strictures. Now, this is the diagram we need to know very thoroughly. Especially, I want to highlight this last part of the bile duct. It joins with the pancreatic duct. It opens at the ampulla of water, but there is like an intra-pancreatic part to this bile duct. So that will explain a lot of things. And you know, this is the right hepatic duct, left hepatic duct. This is the common hepatic duct. This is the confluence. If tumor happens here, you call it cholangiocarcinoma. So this is like a basic anatomical things. Next thing now, when we get a history, our aim of our history taking is come into a diagnosis or differential diagnosis. Then we need to find the etiology, like we discussed in the previous slide, benign, malignant, if so what. Then we need to know any complications happen due to this disease or presentation itself. For an example, if you have a bile duct obstruction, the primary problem is your bile is not flowing into the duodenum and downstream to the small bowel and the colon. So that is a basic problem underlying problem in this. So when this happens, one thing happens is you can get a fat malabsorption because that is due to the disruption of the intrahepatic circulation and other things. Other thing is your renal failure. Other thing is your coagulopathy. Now, if you look at the obstructed biliary system, if some infection is introduced due to some instrumentation or spontaneously, that system is obstructed. It's not draining, so it's a direct infection into the liver and the bile ducts, which is called cholangitis, which has a very serious consequences leading to the sepsis and multi-organ failure. Even it has a very high mortality. So how do you identify cholangitis? Everybody in this audience, I'm sure, heard of Charcot's trial, which was John in a patient with jaundice who had a right upper quadrant pain and a fever and fever with chills and rigors. Until proven otherwise, it is cholangitis. Then renal failure also can happen if I'm not going into the finer details of this. So you need to find out why the renal failure happens. Then the coagulopathy, with the disruption of intrahepatic circulation, you can get a certain vitamin deficiency. So you need to relate all these things. You need to explore all these theories in your patient within the 10 minutes given. Now, if you look at why the coagulation happens, this says due to the vitamin K malabsorption, which is required for the gamma carboxylation of these factors mentioned here. And therefore, it causes prolongation of extrinsic pathway. Therefore, INR is prolonged. That's why we check INR on this patient. That's why we don't give any IM injections to this patient, which can. That's why we give vitamin K intravenous, not IM. So this is the basis of that. Now, again, if I summarize what I said, is this obstructive jaundice? Am I dealing with a patient with obstructive jaundice? What is the reason for obstruction? So this is your analysis of presenting complaint. Is it benign or malignant? Are there any complications due to this disease process itself? Now, just to mention a few things, jaundice, again, obstructive jaundice, if it is a painful obstructive jaundice, pain means it should be the biliary pain. The epigastric pain, your right upper quadrant pain, radiating to back, suggestive of previous like gallstones. In that setting, if this happens, again, it's obstructive jaundice. But you remember, with cholangitis also, you can get pain. So that's a like additional thing. So usually these kind of patients, due to the gallstones, they don't have any like other symptoms, like systemic symptoms, your constitutional symptoms like anorexia or weight loss. But that is in contrast to the malignant obstructive jaundice. Usually these patients with malignancy causing obstructive jaundice, they do have other features like weight loss, anorexia. So this is why you need to get all the chronology of the symptoms and analyze which happens first. So we'll go and we'll check what is that. So I'm still stressing on the history because the history is the foundation for everything in your long case. If you are not analyzing the history in a good way, it's sometimes difficult to come into the final diagnosis. Now, painful and painless. So remember in simple words, if it is painful, you consider common bile duct stones. If it is painless, you think about the malignant cause. Then the other associated symptoms. In relation to the jaundice, so you analyze the duration of other associated symptoms. Now, for an example, if you have a biliary malignancy, usually your bile duct will get obstructed first. You will have obstructive jaundice first, and these tumors can metastasize. You can get jaundice, you can get anorexia and weight loss. But when compared to that, if you have pancreatic malignancy, your weight loss, anorexia are early signs. Jaundice is not hard and fast rules. This is our general observation and explanation, right? With that, if you move further forward, I want to again highlight if you have CBD stones, as I mentioned earlier, ask about the biliary colic, ask about previous dyspeptic symptoms. If you suspect temporary tumor or pancreatic head tumor, ask about the constitutional symptoms. Don't forget that. And also, I mentioned the bottom part of the bile duct which goes through the pancreatic head. So ask about the history of chronic pancreatitis, recurrent episodes of epigastric pain radiating to back in the background of alcohol consumption, the alcohol misuse, as well as recent history of like diabetes. Again, diabetes is a clue for you to identify your chronic pancreatitis due to the endocrine failure of the gland. So we always try to recognize patterns in disease diagnosis. There's no hard fast. There are no you say katapadang thing. So what we need to find out is in the patient what is going on. So we always need to analyze the particular patient we are dealing with, not the patient we have evaluated previously of course, the previous experience is very important, but your story should be relevant to the particular patient given. So that is one of the very important message I want to convey here. So each of these diagnoses has different set of symptoms, alteration of the duration. So that's why this pattern recognition is important in terms of coming into a diagnosis, as well as when you try to identify the complications and the etiology. Now again, biliary stricture, if you want to say, you ask for the previous biliary instrumentation, previous hepatobiliary surgery. For an example, the laparoscopic polycystectomy, one of the commonest surgical procedures performed. You know, the iatrogenic bile duct, the bile duct can be get damaged sometimes during the laparoscopic polycystectomy. If such a patient presented with jaundice, you always think about whether that could be the etiology. That's what I was trying to highlight so far. Then if we go along, here now, cholangitis, again, don't miss, as I mentioned about the Charcot side, but the severe cholangitis, you have your blood pressure, the hypertension due to the sepsis, altered mental status. That's again again the additional features of severe cholangitis. Now again, history taking, you know, the old days we like presenting complaint, history of presenting complaint, past surgical history, past medical history, allergic history. So these are the like check boxes you have to do. But again, make your history like a nice story. So whenever things relevant, you take this thing in a way your history flows like a story. Now, for an example, let's say you are dealing with a patient with chronic pancreatitis, the alcohol consumption is important. So that might be the etiology of the chronic pancreatitis. So rather than mentioning that in a very artificial manner in a latter part of your history, you combine that to your analysis of presenting complaint. Again, family history is important in certain malignancies. Smoking is one of the strongest risk factor of the one of the well-proven and strongest risk factor of pancreatic tumor, pancreatic carcinoma. So you connect all these things. So this is the other thing I want to highlight. Then, so once you do that, again, always one other good practice is to assess your patient's fitness for surgery and anesthesia. This is what you call MET scores, metabolic equivalent of task. You ask whether your patient can climb a flight of stairs, whether he can walk like 200 meters without getting breathless. So this is like a crude measurements. So you can get echoes, you can get other sophisticated other investigation like CPET, the cardiopulmonary exercise testing, but your clinical sense matters most. So again, that is again a part of your history. Then you ask, what were the investigation intervention done so far at the analysis of presenting complaint? Most patients will say, okay, I had ultrasound scan. So you need to identify again when you are dealing with a patient, what is the level of understanding of your patient. Now, you need to go for a lay language sometimes to understand your patient, because otherwise your question might not be received by the other end, your patient. In that case, you will not get correct information, because history taking is essentially a testing of information gathering. So gel gala scan එකක් කරාද? You can ask like that. Whether somebody has put your gel on your tummy and some probe like thing kept on your tummy, and so this, you know, this ultrasound scan. Like that, you know how to ask for a CT scan, what blood test has been done, whether the ERCP, the endoscopic retrograde cholangiopancreatography has been done. So all these things we need to analyze whether it's done or not. And if any complications happens due to those interventions also, you need to analyze. A good student will pick up these things. Actually, our aim is to make a good house service. So these things are actually mandatory. There's no optional. Then you can complete the rest of the history like allergies, which is important if you are planning for a CT scan, if your patient renal function is, and again margin, you need to take these things into account, whether the patient is having any contrast allergy in the previous, any allergies. So these are the things, other important things in your history taking. So with that, we will move into the major salient points of your examination. Always in the examination, you know, inspection come first, then the palpation, when necessary percussion and auscultation and percussion. Inspection is the guide for you a lot of things. So general examination, you inspect your patient. You have to be like a, now let's say you have to have a step back and have a look at your patient. Always remember there is a patient with a problem on your examination bed. So part of the problem has been identified by your history taking. Rest you will do with your examination. The examination is also part of narrowing down your differential diagnosis further down. You will understand why when we go along, right? Now, you confirm your patient is icteric. Again, the hydration status. Again, you know your left supraclavicular lymph node in between the two heads of the sternocleidomastoid on the left side. We call Virchow's node. If it is hard, enlarged, fixed, so that is again a important sign, although it's not commonly seen. Sometimes if you look, you will identify. Then your scratch marks, shiny nails, ankle edema, which is a reflection of the nutritional status, any signs of previous liver disease, all these things are important. And the weight loss, now your nutritional assessment, like these patients are sometimes having weight loss, they're checking the BMI, looking for nutritional deficiencies, like anemia itself is a sign of nutritional deficiency, and the angular stomatitis, other like ankle edema. So all these things will give a clue to the nutritional status, which is again important because it's the effect of the disease and which has implications on in the intervention you are going to do. Let's say you are going to do surgery, you need to nutritionally optimize your patient. That is one of your management options. So examination will provide all the clues to these kind of things. All right. Then other thing is your abdominal. Give me a second. I think some of the links provided not working. Give me a second. I want to share this link. Some of the medical students are also asking about that. So give me a second. So far, any questions? Actually, you can ask. Are there any questions up to now? Any questions up to now? I like to hear some voices from other side because otherwise I feel very boring. It's like I'm speaking to a screen actually. So these are the drawbacks of these online things.
No, sir.
We'll take the discussion at the end actually. So then abdominal examination again, inspection. Now inspection again, you look for the shape of the abdomen, scaphoid abdomen, abdominal distension, maybe a clue to your ascites, and then the previous surgical scars. And you know what is systemic Joseph nodule is like a sign of disseminated pancreatic tumors, right? So that's why these things are important. Again, the palpation. Before you touch your patient's abdomen, always ask whether there's any point particularly painful, which is called tenderness. So you start from another area, then gradually come there without hurting the patient. So these are your some of the tips and tricks for the examination. Then the palpable gallbladder. If your patient is having obstructive jaundice, you must always check whether the gallbladder is palpable. But in an exam setting, exam is an artificial setting. But again, when you deal with the patient on day-to-day practice, always feel for this. Then that will give some practice. So then even in a difficult situation like in exam, you should be able to detect that. Understand? So palpable gallbladder is whether if the gallbladder is palpable. Again, you look whether it's tender or not, because tender gallbladder is a sign of cholangitis. If it is a cholecystitis with some bile duct stones, you may have a Murphy's sign. That's the other thing. Understand? Without evidence of cholangitis. Then again, percussion, you look for the ascites. The palpation, again, you can look for other abdominal masses, the liver enlargement, if the liver is enlarged, how many centimeters. You need to give a in detail description, like what is the liver span in the midclavicular line, like what is the upper border, what is the lower border. So all these, when you present all these things. So that is very briefly about the abdominal examination. Then just to tell you about this so-called the Courvoisier's law, that is, in a patient with obstructive jaundice, if the gallbladder is palpable, that is unlikely to be due to gallstone with some exception. If you have a double pathology, so it's always most of the time it's due to the malignant distal bile duct obstruction is the one. There are some questions, but we will take it at the end in the chat box, right? Then I'll just briefly mention like a typical scenario. Again, a 69-year-old male, ASA2, ASA is how do you classify your comorbidities, right? Two, then the mid scores I mentioned, presented with progressive painless obstructive jaundice. These words are important. Now you need to summarize your history taking an examination. You will be given 5 minutes. Within that 5 minutes, you need to make a summary of your own. So if your jaundice is painless, you say it's painless jaundice because that will differentiate a lot of things. And the duration. Right now, when you say obstructive jaundice, again, you can cut this dark urine, pale stool, fluoride. That will anyway include in that term. And also the other constitutional symptoms for 4 months duration, like significant weight loss and anorexia, right? And there are no complications like cholangitis, malabsorption or bleeding manifestation. But with the ASA2, you have high diabetes and hypertension, no previous surgical history of allergies, adequate family support. On examination, obstructive jaundice is confirmed, and there's a palpable gallbladder. Why this gallbladder palpable thing is so important? Now, we need to go back to our diagram here to explain that. Now, this is your gallbladder here. This is your biliary tree here. Now, if you have obstruction here, confined to the here, proximal to the insertion of cystic duct, your gallbladder will not be palpable. That is technically very easy to identify. When compared to that, if something here and infiltrating up to this level, then your gallbladder cystic duct is blocked and it will get enlarged. And again, if you have obstruction, malignancy here, it will be again distended. Now, let's say your patient had an anorexia, weight loss like symptoms in the background of obstructive jaundice, you have a palpable gallbladder. That will differentiate your proximal malignant biliary obstruction from the distal malignant biliary obstruction. That is why we need to use this information in a very pragmatic way, in a very like practical way when you're dealing with your patient. All right. Then again, if I go to the certain investigation, again now we need to get a full blood count done. A reason for that is to look for a platelet level and look for the hemoglobin level. Because these patients are like very malnourished in the setting of malignancy, anorexia, weight loss, they could have low hemoglobin level, which you might need to optimize for your certain intervention and the platelet count. So you say, I will do a full blood count in view of looking into these parameters specifically. Then the bilirubin, again, interpretation of obstructive jaundice is direct hyperbilirubinemia, where your direct bilirubin is more than 20% of your total. And again, the other liver enzyme is alkaline phosphatase and gamma GT, especially the alkaline phosphatase, which is secreted by the biliary epithelium, will be grossly elevated. Albumin level, again, is a liver function test. Again, it's like a reflection of your nutritional status. And the when compared to the ALP, the AST/ALTs will be not much elevated in a patient with malignant bile duct obstruction. Now, other thing is the CA19-9, which is a very common investigation we see to be performed on patient with obstructive jaundice. But again, remember, when you have elevated bilirubin levels, your assay to detect the CA19-9 is falsely elevated. Usually what we do is, when you have an obstruction, you put the stent in, ERCP and biliary stent, wait for 2 to 3 weeks, when your bilirubin cell level will go down, then that is the point you need to get this CA19-9 level done, because although it's available, it has its own cost. It's around 40,000 rupees if you analyze the cost for the laboratory assay. Therefore, we need to utilize our healthcare facilities also in a very practical manner, especially in a setting like Sri Lanka, where there are a lot of constraints in the management of patients in terms of various things. So, if you do it and if you elevate again, you don't have any value of that. So, therefore, again, CA 99 level is not a game changer suddenly. And therefore, do it in a timely manner. So, but other investigation, those are mandatory ones to confirm your obstructive jaundice, to assess the complication like coagulation, so look at the nutritional status. So all these things happen concurrently with this level. Then, once you do these things, so this is the interpretation I mentioned, imaging. The ultrasound scan, which is one of the most commonly used cross-sectional imaging that everybody knows about ultrasound scan. In any setup, you have a radiologist and ultrasound scan, which is very commonly available thing, even more than the CT. So in an ultrasound scan of this kind of patient, let's say now again, you are not going to interpret the ultrasound alone. You are seeing, you have a history, you have a examination finding, you have your bilirubin levels and other things. With that, you interpret your ultrasound scan. Because by the time you reach there, you have a lot of other clues to your diagnosis. But main thing in ultrasound scan is your duct dilatation. Your dilatation of the intrahepatic ducts, which itself tells you are dealing with obstructive jaundice. The normal diameter of the duct is 6 millimeters. But after like 40, 50 years, there's an age-related dilatation as well. But more than 80 is again considered as a dilated duct. So again, whether it's common bile duct dilated, whether it's only intrahepatic duct dilated, whether the whole system is dilated is important thing, because that will determine your proximal versus distal obstruction. Again, look for the gallbladder. Gallbladder wall thickness. Are there any calculi inside? Are there any pericholecystic fluid suggestive of symptomatic gallstones, like in the setting of cholecystitis? Then look for the liver. Are there any deposits in the liver? And if there are any lymph nodes, again, the ultrasound, other thing you need to remember is operator dependent. So properly done scan would say whether there are other nodes, and those things also pick up, but what I mentioned earlier was essential information. So in this diagram below the table, it says dilatation and the possible causes. So that is about the ultrasound scan in a patient with obstructive jaundice. Then other thing is your CT scan. So somebody might ask why you are doing a CT scan. Now, if you suspect a malignancy, doing a CT scan is to stage the disease. Now, one of the principles I could mention in the early side is when you plan your investigation, you need to plan investigation to confirm your diagnosis, confirm the obstructive jaundice, identify its own complications, assess the fitness of surgeon for fitness of patients for the surgery, which will come later. And if you are suspecting malignancy, and to find out the level of obstruction, that is where your MRCP will come, the magnetic resonance cholangiopancreatic. And if you are suspecting a malignancy, to assess the staging. So always we should have a rational plan when we request the investigation, because investigations are costly, and we should not investigate without any rational plan. So CT scan, again, it will stage, diagnose, find out where's the lump, especially the pancreatic tumors. I'm not going into the fine details which might not required at your level, because this lecture is aimed at the undergraduates. So I have tailored my talk to that. So usually they will appear as a lump in the head of the pancreas. So with the duct dilatation, your CBD is dilated, your pancreatic duct dilated, you call it double duct sign. So again, it will help to detect the liver metastasis and assess the resectability of the liver. That means relationship of the tumor to the underlying vessels. Then again, MRCP, again, it will better visualize. It's one of the very sensitive investigation to find out the luminal obstruction within the biliary tree. So visualize the biliary tree. But ERCP, again, it's not a diagnostic thing. It's used for the therapeutic purposes, but it has its own diagnostic advantages But for the diagnosis, only you never do ERCP because it's invasive investigation. It has its own very high complication like gallstone, post ERCP pancreatitis, perforation of the duodenum, bleeding from the ampulla, acute pancreatitis, acute cholangitis, even a death due to this. So therefore, as house officer, you should know how to minimize these complications by properly preparing this patient for a ERCP, which needs hydration, assessment of the coagulation. So that's why in a history you take all these details because you need to make a plan for your patient. With that, we will move forward. So again, a very brief clinical scenario to make this more interactive. Otherwise, this looks very boring with more theory. 30-year-old female, 8 hours history of acute epigastric and right upper quadrant pain, radiating to the back, non-bilious vomiting, radiating to the back along the rib cage on the right side. Previously well except for the dyspeptic symptom for which treated with omeprazole 20 daily from the general practitioner. On examination, hemodynamic stable, slightly icteric, afebrile. On the abdomen, there is a right upper quadrant tenderness with guarding. So we need to find out what is the diagnosis. So possible diagnosis is, as the patient is jaundice, with all this history in the setting of like biliary colic, might be having symptomatic gallstone, maybe a common bile duct stone, as well as bit of a cholecystitis. So that is the probable diagnosis. So this is typically the biliary colic, which is described during that slide of the history. So you need to find out some, this is a bit of a homework. Why do biliary colic happens? Why it radiates to the back? What is the reason of distribution of pain in the biliary colic? So you need to know this like a referred pain, the anatomical basis of these things. So biliary colic is one of the common things. So you know the phrenic nerve. So this is the basis of that, right? With the interest of the time, I will move forward. Then about this gallbladder and the other things. So function of the gallbladder, you know, is right briefly, transiently store the bile, concentrate the bile at the mucus, and what will happen if you remove the gallbladder and what changes will happen in the gallbladder and the bile duct during the meals. You know your physiology, cholecystokinin, pancreatocinin. So all these things will explain your biliary colic. So interest of the time, I would exclude these theoretical slides. Then you need to know about the why gallstones happen. It's due to the super saturation. This is a bit of a theory which is important for you to generate a discussion in your long case panel in the second way of your long case, which is your history presentation and discussion. You have 10 minutes, minimum 2 minutes for history presentation, and then rest of the thing you need to carry out with your discussion. So this knowledge is important. Your bile, again, it's like a equilibrium between the nucleating and anti-nucleating factors. When there's an imbalance between these factors, there is a supersaturation of bile, the cholesterol. This will result in stone formation. And you know the different types of biliary calculi. Your cholesterol stones and these are pigmented stone, the mixed stones. And you should know if you get X-ray, only 10% of the time you can catch the biliary stones. When compared to renal stone, which is 90%. Again, one of the other thing you need to know is 80% of these gallbladder stones are silent. They detect because of the other reasons. You get ultrasound scan, you find gallstone, which should not be intervened. But if you get a jaundice due to the common bile duct stones, again, that is part of the symptomatic gallstone. The definitive management is laparoscopic cholecystectomy. You need to remove that gallbladder. That is only 20% of the time in the whole population. So this is one of the other things. And you know by etiology, when you are dealing with a patient, you know who get the gallstone. So I don't have to elaborate on these things. So these slides are actually self-explanatory. And this slide I will take some more time to explain the sequelae of the gallstones. Again, you need to know if you get a patient, you need to analyze this. So gallstone within the gallbladder can give rise to biliary colic, which can progress into the acute cholecystitis. Actually, the chronic cholecystitis is a histological diagnosis with the repeated bouts of acute cholecystitis. Again, especially in diabetic patient, if you have a stone in the neck of the gallbladder, if there's a superarid infection, which results in empyema of the gallbladder, which is again a biliary emergency, which has to be dealt urgently. These are the gallbladders you need to drain with a percutaneous transhepatic cholecystectomy, treat with antibiotics, manage the sepsis, then do a laparoscopic cholecystectomy later. So again, so there are certain emergencies. Again, the mucocele, again, which is very common, painful condition with the impaction of the stone within the gallbladder and neck. Again, indication for cholecystectomy. So all these things will happen while your gallstones are remaining within the gallbladder. Then, if your stones migrated in a normal pathway, like your common bile duct down, you can get a common bile duct stone, which is called choledocholytitis. These terms you need to know, which can cause jaundice. If you get an infection, you can get a cholangitis due to that. If this gallstone irritates at the ampulla, the pancreatic duct, you can get acute pancreatitis, which we call acute biliary pancreatitis or gallstone pancreatitis. And that is other thing. And then if these migrates along the aberrant pathways, like if it erodes into the duodenum, you can get a gallstone ileus, which is a very rare cause of small bowel obstruction. And sometimes in a Mirici syndrome, your neck stone, it hasn't gone into the common hepatic duct, but it's pressing the common hepatic duct, like external compression, which we mentioned earlier. That is also like a cause of obstructive jaundice. So management of gallstone, again, which I have mentioned, the gold standard definitive diagnosis is laparoscopic cholecystectomy. All right. Asymptomatic gallstone, if you get a patient, you need a reassurance. Again, these patients need weight reduction, diet. And again, if you get a biliary colic, you need a analgesic. If you get a cholecystitis, cholangitis, empyema, you need to treat with antibiotic, resuscitation, IV fluid. So these are the management aims. Again, usually it's interval cholecystectomy. You wait 6 weeks for the inflammation to reduce. But if you have a theater time, if you have expertise, if your patient is stable, again, you can attempt a hot cholecystectomy, just a mention only. So again, don't remember cholangitis is a killer. Empyema of the gallbladder is a killer. These are the like a heart attacks, like you have a gallbladder attacks. So these has to be dealt then and there. Otherwise, you have mortality. Even though it's benign disease, it carries very high mortality with these things. So early detection is important. That's why we get history, we do examination, we do necessary investigation and investigation timely as a first contact care doctor. You are the most junior but most important, one of the most important members in the team. If you provide correct information, then it's easy for your seniors to plan these things. Very briefly, the case number 2, 65-year-old patient worsening jaundice in the background of anorexia and weight loss with recent onset diabetes, who was a past smoker for the 1 month duration. And there's a palpable gallbladder in an obstructive jaundice, this patient on examination. So, is the gallbladder palpable? Yes. So, in that case, you know Courvoisier's law, this looks like a malignant biliary obstruction due to one of the causes which we have mentioned here, most likely, right? So, again, one other message I want to give is if your patient, especially elderly, having new onset diabetes, that itself is a presenting feature of pancreatic head tumor, pancreatic malignancy. So never forget. On the other hand, your patient with diabetes who has a recent derangement of the glycemic control, again, another feature of this, these might coexist with your obstructive jaundice. So that will provide little clues to confirm your diagnosis. So then you will feel confident within yourself, especially when you are in exam, if you know these things. Then again, other thing, if you have a jaundice with so had a transient jaundice, if you had again an episode of acute pancreatitis, again, don't forget one of the presenting symptoms of pancreatic tumor, pancreatic cancer is acute pancreatitis, especially in elderly patient, more than like 40, 50 years, 60 years. Don't forget, that's why once this acute pancreatitis is settled, you need to investigate this patient with a CT scan. Now again, another case to generate some interest. So this is again a Patient jaundice with other constitutional symptoms. You have ALP more than 1000, your total bilirubin 12, direct bilirubin 8, so that confirms your obstructive jaundice. BMI is 20, and abdomen there's a palpable gallbladder, ultrasound showed pancreatic head mass, and the dilated ducts, both ducts, pancreatic duct as well as the CBD, which is 1.2 centimeters, with intrahepatic duct dilatation. Liver, there were no focal lesions. So management plan, you assess this patient. He's a very fit guy. Med scores beyond 4 actually. But you know, there's a bit of a prehabilitation. The prehabilitation is optimizing your patient comorbidities, making their mental status, regular physical exercise, nutritional optimization. All these things are part of your preoperative assessment in a patient like this. Now, this patient had a pancreatic ductal adenocarcinoma. So if you have a pancreatic ductal adenocarcinoma, primary mode of treatment is surgery if it is resectable. But again, there are certain tumors which you can't operate at once. You have to give some chemoradiation, which is not, again, assessment of that is beyond your limit. So you need chemoradiotherapy and then assess for surgery, which is called borderline group. And there are definitely certain patients who are not resectable at all, who are not treatable at all because of metastasis. This is the group which will go for palliation. In a surgery, you need to know in obstructive jaundice patient is due to the head obstruction, pancreatic head tumor. The curative option is Whipple's pancreaticoduodenectomy. These are real images of one of our patients we have operated. So this is your pylorus of the stomach. This is your C loop of the duodenum. Duodenum has been mobilized from the retroperitoneum. And you see there's a mass in this pancreatic head. Even in this specimen, you see this area. This is a patient actually who had a T2N1 at the end of the resection. Histology had a pancreatic tumor. You can see this is the portal vein and this is your remaining pancreatic stump. The pancreas has been divided from the neck and removed. So your pylorus is here, your total duodenum is here, proximal jejunum here, and your uncinate process and the head of the pancreas here on the specimen. So this is one of the, because if your assessment is correct, you can catch this patient early, you can cure them to a certain degree. So that is why that assessment is important. Again, this is such a patient. Here I just want to briefly mention, this is your, now once you do this, if I go back, so this is your original view and this is your reconstructed view. So you have to know roughly there were 3 anastomosis. One is your pancreas jejunum, pancreaticojejunostomy, and the pancreas, and then your bile duct to the jejunum, hepaticojejunostomy, then your gastrojejunostomy. So these are the real pictures of this is one of the hepaticojejunostomy pictures, right? The palliative option, again, if I discuss very briefly, patients who are not fit for intervention, you can palliate the bile duct obstruction with ERCP and metal stent. That is the best. And if your patient, sometimes you can get a gastric outlet obstruction in the setting of metastatic disease, for which you need to palliate the gastric outlet obstruction. Nowadays, you have your good interventional endoscopy service in this country. Can request this patient for like duodenal stent. Again, if it is not, you can do a gastrojejunostomy as a palliative bypass. For the pain, we know medication, the radiotherapy, and the celiac plexus block. These are the different lines of treatment. And for the bleeding, it's mainly the embolization. With that, we'll come to the last patient. This is a 69-year-old. All these are real patients we have dealt with in our unit. So this is a 69-year-old female. Again, well-controlled diabetes and hypertension, past TIA, the transient ischemic attack. She had a transient episode of jaundice and anorexia and weight loss, and biochemistry suggestive of direct hyperbilirubinemia, and MRCP-CT both were suggestive of a Hilar. That means at the where your left and right hepatic ducts join the hilum, there's an obstruction. So actually, this patient had a Hilar cholangiocarcinoma. Again, Hilar cholangiocarcinoma. The selected patient, if you refer them early, they are suitable for surgery. Again, like you have curative option, you have like oncological options like in chemotherapy, and you have the palliative option. So this is a patient. She had again a hepatectomy to clear the tumor. You can see the Hilar structures here, liver Hilar structures, the portal vein, your common hepatic artery, the common bile duct, and this is the like a remnant liver after the resection. So this patient had a complete removal of the disease. So this was done in 2021. this patient is still alive. So I just want to highlight it is not an uncurable disease provided with early detection that you all will do with your good history taking and examination. So this is that patient specimen. Like now, I would like to conclude. I don't have many take-home messages. In a long case, you need to utilize your time effectively. You need to plan certain things with history taking and examination and how to make your summary and how to generate discussion. Again, don't remember, if you have a painful jaundice without a palpable gallbladder, think about common bile duct stones. If you have a painless progressive jaundice with a palpable gallbladder, think about a biliary malignancy as an etiology. Rest of the things are we discuss. It's not difficult. So these are the more important two messages out of this lecture. With that, I would happy to take any question. Actually, there are a few questions already shooted on the chat, so I'll read one. If there are anything from the audience, actually, I would like to take these questions. First thing is, can you please upload the last one? That is not relevant to me, I think. Are there any questions actually? Of course, we can upload the presentation. That is not a problem. We can do that. So thank you for listening. So if there are any questions, I'm happy to answer. I can't see any questions here actually in the chat also.
If you have a question, you can ask directly from Dr. Duminda Subasinghe. Otherwise, that other thing, you can drop the message to our chat box.
There's one question again. In a patient with a Klatskin tumor, is there any cause that patient is having palpable gallbladder? I had one patient like that, and I was thinking of coexisting mucocele because ultrasound showed. So it's a very good question, actually. That means you have to look at your patient very thoroughly, and you thought of something. Actually, the answer to your question is when you have a tumor, the bile duct is a very small potential space. When you have a tumor in your hilum, it can infiltrate down the bile duct. So your patient might have a involvement of the cystic CBD junction due to that Klatskin tumor. That's why your patient's gallbladder was palpable. Because of the secondary to that obstruction, your gallbladder mucus things will get accumulated and gallbladder will get distended. So that is the explanation for that. The second question is among acute cholecystitis and acute cholangitis, what would show prominent loss of appetite and loss of weight? Loss of weight and loss of appetite actually not directly relevant. If you have acute cholangitis, now cholecystitis, you don't have jaundice. In pure cholecystitis, you have fever, you have Murphy's sign, you have previous history of gallstones like biliary colic, and you diagnose based on that. In a cholangitis, again, cholangitis usually happens due to gallstones. You have fever and obstructive jaundice is the main thing which will differentiate. So again, anorexia and weight loss are not directly related to that presentation. The time duration of cholecystectomy after acute attack, again, there's no concrete answers here. Usually you wait for 6 weeks. You know, most of the places, because of the malignant diseases and other cancer operation, benign diseases will get postponed and have a waiting list. So anyway, not because of that, anyway, it's a good idea to wait for 6 weeks, let the inflammation settle and do a cholecystectomy. For at your level, 6 weeks is the answer. The next question is, if a patient presents with painless obstructive jaundice but no palpable gallbladder, of course it can happen if it is in a Hilar cholangiocarcinoma. It can happen. So there's etiology for that. How to differentiate acute cholecystitis, gallstone, cholangitis, which we have already answered, right? Then the next question is, should we supposed to give running commentary or presenting findings after the exam? It's again depends. Now, to save your time, it's always good to describe the things once you see. But on the other hand, it depends on your examiner's command as well. So there's, again, you listen to the command and follow that. But again, I would more for this running commentary because that will save the time, because you have only 5 minutes. Even in the short case, long case, you have only 5 minutes for the examination. So yes, some questions are really going up and up. I can't, difficult to catch them. Wait for a second. Hot and cold cholecystectomy. Hot cholecystectomy is during the same episode of cholecystitis. Usually, it's easy to do within first 72 hours. You do a cholecystectomy. If you have a theater time, if you have experience on that, you can do it safely. But cold means is 6 weeks. 6 weeks versus 72 hours. Then any advantage of ERCP with regarding the fluid collection in the lasers? Again, this is a bit of out of the question for this topic, but I would answer that yes, obviously, because it's internal drainage. You drain, you go to the stomach. Actually, it's not with the ERCP. Actually, it's with the EUS, which is called endoscopic ultrasound. So fluid collection, there's no advantage with the ERCP. It's EUS. So because the pancreatic collections can be accessed with the investigation called endoscopic ultrasound. Biliary colic, can it cause transient jaundice? Pure biliary colic, not. Goals and investigation for CBD obstruction and gallbladder stone. Again, gallbladder stone ultrasound is more than enough. Even a good ultrasound might pick up your duct dilatation, and with history, you can diagnose CBD obstruction. But MRCP again, it's like for the biliary calculi, again, it's more sensitive than the ultrasound scan. Yeah. Then sir, should we offer digital rectal examination during observed history taking of a patient with obstructive jaundice? Again, a good question, but again, you see, now let's say you have a patient with stomach cancer, having Hilar lymph nodes. Due to that obstructive jaundice, again, that can cause blemishes. You can offer these things. You are not going to do things, but yeah, there is some role, but not directly. I think recording is going on. I think that is from not my side. I think it has been already done. I said okay for that. So don't worry about that. So I think I have answered all the questions up to now. Any further questions from the audience? Please ask question if you have. You don't have to. You can open your mics and ask. I promised I will. I would stick to the time. I think it's 1 hour now. But if there are any questions,
Excuse
I
me,
would
sir.
still happy to answer.
Excuse me, sir.
Yeah.
Patient with transient or
Can you just speak little bit loud? I can't hear actually. Yeah.
the patient
Hello.
present with transient or intermittent jaundice, isn't it more likely to be periampulal carcinoma?
These are actually theoretical things. Usually, now the theory is when you have a tumor in the ampulla, your center is the most vulnerable place for ischemia. Then there's a bit of a slough, like a necrosis of the tumor, and then your jaundice will relieved. Don't worry about that. If you have like a progressive thing, jaundice, with the background, we don't rely on one symptom only. So that's why I said pattern recognition is important. You have a patient with weight loss, you have a patient with the anorexia, then even if you have a transient or whatever the jaundice, you should think about malignancy. Yeah, that's in theoretically, yes. What you said is correct. But sometimes you will not see these theoretical things always.
Okay, thank you.
Any further questions? Place of EBD in patient with cholangiocarcinoma, of course, yes, that is one of the very useful things. EBD is available by more than ERCP and it's easy to perform. You can do it under local anesthesia and ultrasound guidance. It's very useful. If you have like in empyema, you place the percutaneous transhepatic cholecystostomy in a cholangitis. You don't have a facility to refer for a ERCP. You can put a EBD and then you can get ERCP later. Yes. What is the goal stand for acute cholecystitis? There's nothing called that. Like it depends on your circumstances. Patient coming with multiple CBD calculi in the ultrasound scan. but patient denies any obstructive jaundice. CBDR, right? Okay. I specifically a very good question actually. This is what you call biliary ectasia. These are primary biliary bile duct calculi. Sometimes biliary ectasia is like choledochosis, kind of a choledochosis. Your liver functions are normal, but with the biliary stasis, you get like a stack of stones in the biliary tree. It's possible. Of course, very good question. Again, you can have, but no jaundice at all. So if your patient is having gallstones, dilated biliary tree, still your LFTs are normal. That is called choledochosis or biliary ectasia. It can happen. Again, relieving of pruritus, you use Veritan, you use various things, but definitive thing is you have to relieve your bile duct obstruction. And nutritional support following gallbladder removal. After that, there's nothing. You usually gallbladder disease happens in patients who are very obese, so weight loss and diabetes control. These are the things important. After pancreatic surgery, yes, you can get endocrine and exocrine failure. So for that, you might need to supplement your pancreatic enzymes. You have to treat with insulin for your endocrine failure. Yeah. Is there options other than cholecystectomy in bile stones in gallbladder? If the patient is symptomatic without cholecystitis, even without cholecystitis, if you have a symptomatic gallstone, like in the sense of biliary colic, cholecystectomy is the definitive management because your gallbladder is unhealthy. There's nothing called you can remove the stones like in a kidney stone. You remove the stone and keep the gallbladder. There's no surgery like that, and there's no place for laser also. So you need to take the gallbladder off, and there are a lot of people who can live without the gallbladder, so it's not a problem. Is there a possibility of patient developed recurrent choledocholitis even after undergoing cholecystectomy? Yes, the primary ductal calculi. So gallbladder calculi can migrate into the bile duct. Those are secondary stones. De novo, the stones can happen within the biliary system due to the stasis. So yes, answer is yes. Any further questions? I think all the questions are.
Thank you very much, Dr. Duminda Subasinghe, giving us time to discuss a very important topic with our students. I know that you have a very busy schedules. Actually, not only undergraduate that you are doing it, some postgraduate activities also. Therefore, it was a actually, this is a very important topic. Other thing, this was a very fruitful discussion. Therefore, thanks again. I want to tell you that our next webinar, it will be on thyroid lump. It will be done by Dr. Vasantika Tudurge. We will share the link in future. Thank you very much. Have a good night.
Thank you everyone, and thanks Dixon for the opportunity and for the great atmosphere. Thanks.